Good morning, everyone. My name is Diane Cohen, Vice President of MacroPro, here today with Yvonne Guibert, and she is with the Institute of Health. How are you, Yvonne?
I'm doing great, Diane. Thanks for having us today.
Oh, we're so happy to have you. So you are in Tampa, is that right?
I'm in Tampa today, yes.
And your doctors are all from California, is that right?
Yeah, they are all in Southern California, near San Diego.
Oh, very, very cool. I'm going to go over some housekeeping, and then we're going to talk a little bit about the holidays and see if we can get everybody to chime in with us. So I just want to remind everybody today, this is worth 1 CEU credit. You must be logged on to the GoToWebinar platform in order to receive your certificate as they take our time and attendance. You will receive a certificate within 1 hour of this broadcast. However, if you don't, it's probably your firewall. So check with your IT department before you start worrying about it, because they could probably release that for you. We do have handouts for today, and there's a lot of information, as Yvonne will tell you in just a moment. So you want to make sure that you download that now from the control console. And then if you have any questions, we are going to try to take some. There's a lot of information that's going to be going on today. You can put them into the question section, and at the end, we will try to get those questions. And then if you would like to watch this again, you can watch it on the MacroPro YouTube channel and rewatch the information. It's always good to kind of have a refresher. So Yvonne, thank you so much for joining me. Can you tell me what you do there over at the Institute?
So yes, of course. Thanks again for having us. I am Vice President of Education Strategy, and what that means is I focus generally on putting together educational sessions like this for the outward-facing community. So that is what I do.
Well, I can really appreciate that. And then tell us a little bit about the Institute.
Oh my goodness. So Institutes of Health is a transdisciplinary biopsychosocial model of care that employs the therapeutic community. We're based in San Diego, Riverside, and El Centro, and we're growing. We're going to be opening up offices in Los Angeles and Anaheim very soon. So what we do is we focused on delayed recovery claims in the workers' compensation system. So there's a lot more I could say, but I'm going to leave it at that for now.
Oh, that's fantastic. And we have the Thanksgiving coming up. So I want to wish all of our audience happy Thanksgiving. Do you have something that you're in particularly grateful for?
Oh my goodness, Diane. So you and I have had a chance to know each other for a while in a very special way with our Comp Laude connection, where we did our People's Choice presentation together. I'm grateful for so many things, but right now I'm grateful to be working with these amazing folks at Institutes of Health. And I'm also looking forward to seeing friends and family at Thanksgiving in Nashville. So I'm looking forward to that.
Oh, that's outstanding. Well, you know, I am grateful for my family. We recently moved, so I'm really happy that I am settling in on that. So I know all of you listening have something that you are happy and about and thankful for. So maybe you can put that in our chat line so we can see it. And we want to thank you very much, Luz, for the Thanksgiving wishes that you just posted. So thank you for that. All right, everyone, I am going to now turn this over to Yvonne. But before I do, I just want to say one thing. For some reason, there's a little bit of mix-up, and some people were thinking that MacroPro is an applicant copy service. I just want to clear up the air on that. MacroPro is a defense-only copy service. So if you were thinking that, you can rest assured that you can utilize us. We are defense only. All right, Yvonne, I'll send this over to you now.
Thank you, Diane. And panel, please go ahead and turn your cameras on. While they're doing that, I wanted to explain this funky slide here. We promoted this session as 10 tips for work comp professionals managing chronic pain claims. And we have decided to rename this to recognizing delayed recovery claims with chronic pain. There's a lot to chronic pain claims, as we're going to get into here, but I just wanted to clarify and be transparent about why we decided to change that slide. And I think as we go through, you will understand. And as Diane said, we have a lot of information. So let's dive right in. And here we go. So first of all, as I already said, I'm Yvonne Guibert, Vice President Education Strategy with Institutes of Health. We also have Dr. Kimberly Tilley. She is Senior Vice President, Clinical Administration with Institutes of Health. I am not going to read the bios here, but I would really like to encourage you all to take a look at them, as Diane said, with the handouts. These folks that I'm presenting with today are very smart and they're very experienced in what we do. And I'd like you to take just a minute to read their bios when you have a minute. We also have Dr. Esther Allmond. She is director of our chronic pain clinic at Institutes of Health. Then we have Dr. Ramzi Ali. He is director of PTSD program at Institutes of Health. And we have Dr. Dalia Pimentel. She is a behavioral medicine specialist at Institutes of Health. So, and I'm again not going to read these objectives, so I want to say thank you, panel, for joining us today. It's been a pleasure to work with you to get this presentation ready. Here are our objectives. Not going to read these, just want to point it out that these are the items that we're going to focus on today in our presentation. And so with that, I want to start handing off to Dr. Ali, who's going to take us through understanding why we're talking about chronic pain. And it's a big deal, isn't it, Dr. Ali?
It is. Thanks, Yvonne, for the warm handoff. So I can just kind of get it started. So I want to talk a little bit about chronic pain statistics. And so chronic pain is a significant problem here in the United States. According to the CDC, it impacts about 1/5 of US adults as well. That's the same number for kids, by the way, as well. And within that population of about 1/3, 7% of US adults experience what's called high impact chronic pain. And that's where it's really debilitating in the context of interpersonal, social, occupational functioning, really affects the day-to-day life in a very significant way. Chronic pain is highly persistent. And so an NIH study showed that about 2/3 of people with chronic pain experience pain beyond a year. In a little bit too, I'm going to talk about what differentiates chronic pain from acute pain or normal pain, but 1 year is a pretty long time. The healthcare costs of chronic pain is pretty staggering. Annually, it's about $560 to $635 billion annually. And then within the workers' comp system, we know that it's also pretty high, and employers spend about $62 billion annually on chronic pain with those worker compensation claims. So it's about $1.19 billion per week. It's also important to note too that physicians receive little to no training on pain, especially chronic pain. And so one of the studies that was found was that about 5 out of 133 medical schools required pain education on an average of 8 hours of total time devoted to pain. So that includes medical school, residency, internships, even those who are attending. Chronic pain, as we've already kind of said, how it can be so debilitating, affects quality of life, one's sleep, all those things. Yvonne, did you want to?
Yeah, so I just wanted to interject here. So that's a lot. And as you see, we're going to get into a lot more detail with that. But the good news is we want you to focus on the fact that 80 to 90% of injuries resolve on their own within the occupational medical system without any additional care. It's the 10 to 20% of claims that require a more advanced, comprehensive approach. And that's what we're going to get into talking to today. So go ahead, Dr. Ali, tell us about pain. What do we need to know?
Sure. So as we're getting going here, we want to just know, like, well, what is the definition of pain as we kind of segue into the whole lecture here? And so according to the International Association for the Study of Pain, they define it as an unpleasant experience, unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Is there some points to keep in mind when we're talking about pain? It's a very personal experience that's influenced by our own biology, our own psychology, and the social factors around us. Pain and nociception are pretty different phenomena. So pain is that subjective experience of one's pain. Nociception is really just kind of the nervous system's ability to kind of work with harmful stimuli. Our life experiences, as I kind of mentioned, really alter the way we think about pain. And so if you think about it from a patient care perspective, pain should always be respected, even if you can't see it, right? If you don't agree with it, everyone's interpretation is always wide. Although pain usually serves as an adaptive role, with chronic pain, we know that it often can have the opposite effect. And in line with that, there are psychological factors of chronic pain that we need to keep in mind when we think about how we're managing our pain symptoms. And so we know that chronic pain absolutely influences more anxiety, right? Concerns about when we're going to get better, helplessness, why won't this get better? Escape or avoidant behaviors, so it could be substance use or addiction to not deal with the pain itself. We know that senses of hopelessness and depression can increase with chronic pain, and we know that chronic pain can also reduce or actually increase pain-related behaviors. Another distinction to make, as I was talking about earlier, we want to look at really quickly, what is the difference between acute pain and chronic pain? And so the conservative estimate of chronic pain is that pain lasts for greater than 3 months. And so if you look at this little arrow here, acute pain is usually less than a month. Well, there's obvious tissue damage. Pain resolves upon healing. And again, it serves as a protective functioning to recover. Whereas chronic pain, conservatively 3 months, even beyond 6 months, pain lasts beyond that expected period of healing, and there's really no more adaptive or protective functioning. Pain is the symptom itself.
Thank you, Dr. Ali. So now we're going to start in with our tips. And so the first tip is no chronic pain.
Yeah, so tip number 1 is to know and understand the nature of chronic pain. And the Neuroorthopedic Institute from Australia, who are actually the leading research group for pain science in the world, they have found overwhelming evidence that knowledge coupled with movement is actually the #1 treatment intervention for treating chronic pain. And this is because there is often not just one singular clear cause for patients that have been in pain for longer than that 3 to 6 month marker. And we need to start considering how each individual's biopsychosocial factors and their individual variability can affect their perception of pain. And once we're able to do this, the patient can start feeling as if they're in control of managing their chronic pain, promoting self-efficacy, and reducing dependency on the healthcare system. Next slide, please. I'm going to start with a quick overview of the 4 essential pain facts, and actually Dr. Ali did a great job outlining a few already. But number 1 is that acute pain is actually a protector. Pain actually protects us and promotes healing. It acts as a safeguard for our body, to keep our body tissue safe. So this is as if you were to put your hand on a hot stove, you don't keep your hand on the stove because it elicits a painful response. We take our hand off the stove, and thus we protect our hand and prevent a 3rd-degree burn. So in this sense, pain is a protective feeling, and that it's essential for our survival. The second essential pain fact, though, is when persistent pain actually overprotects us and prevents recovery. And what this means is that when pain goes on for longer than expected, even after the tissues have healed, our pain system develops a phenomenon known as pain system hypersensitivity. And then essential pain fact number 3 is that we have to respect that many factors can influence our pain, and that our pain system sensitivity can change based on what is happening in your life. So some common factors I might ask my patients are to explore what is influencing their pain levels. It could be what they eat or drink, challenging relationships, work or financial stressors, sleep, activity levels. And once they start recognizing what are these factors that influence their pain, we can go into essential pain fact number 4, in stating that there are many evidence-based ways to reduce pain and promote recovery. Our bodies have this incredible drive to adapt, and it's known as bioplasticity. And so bioplasticity is actually something that contributes to our patient's pain system hypersensitivity, and our bodies have learned pain. But this bioplasticity is also going to be the phenomenon that reduces our pain system hypersensitivity. Next slide, please.
So before we go on to the next slide, I just wanted to reiterate, we were chatting about this before we started, that for the audience, we were talking about any one of these tips we could really talk about for at least an hour. So I just want to kind of give a shout out to the doctors today for synthesizing this so we can move through this quickly. It isn't easy. So on our second tip, and this is also you, Dr. Allmond, right?
Yes. Yeah, tip number 2 is for managing the injured worker with chronic pain or delayed recovery, we want to shift the focus from their symptoms to their function. And the distinction between symptom and function is important in understanding our injured workers' overall health, wellness, and various treatment approaches. So in the next couple slides, we're going to look at a few examples that I want to start noting. I want us to note the differences in the language that we use to eventually describe symptom versus function. So I won't read off all of these examples here, but as you can see, a lot of these symptoms are subjective experiences or signs that indicate something may be wrong with the body or mind. And it's typically what a person feels and reports when there is a health problem. Versus the functions on the right-hand side, you can see that it refers to the ability to perform tasks or engage in activities that are necessary for daily life, work, or physical and mental well-being. So as you can see a few more of these symptoms, they're often the effects of an underlying condition or tissue. And examples include pain, fatigue, dizziness, anxiety, the numbness and tingling, nausea. Whereas the functional problems often involve impairments in mobility, cognitive ability, emotional regulation, or social interaction. So for instance, not being able to walk due to a knee injury. So, big takeaway here is that symptom-focused care may provide short-term relief and helping people feel better by targeting what they feel directly, versus in function-focused care, often they have long-term objectives and it enables people to do more of what they need or want to do and enhancing quality of life and independence. Next slide.
Thank you, Dr. Allmond. Before you start, do any of the other panelists have anything to say about what we just covered? We covered a good chunk of information there, so I just wanted to give them an opportunity to chime in if they want to. Nothing? Okay. Dr. Allmond, is this you still?
Yep. The next tip number 3, when recognizing and managing an injured worker with delayed recovery, it is important to note how crucial documentation is so that we can understand the full scope of their injury. And some of these go without saying, but reviewing medical documentation thoroughly. I want to know about the date of injury, the mechanism of injury, any sort of ongoing treatments or previous treatments that my patients have received in the past, what their response was to those treatments. Was it poor? Was it effective? And then also understand, knowing what the injured workers or my patient's adherence was to the medical advice that is given from their providers. Next slide, please. We also want to make sure that we're incorporating objective evidence, because many times, like the previous tip suggested, we go off of the subjective documentation from what the injured worker is telling us about their pain levels. So utilizing all those diagnostic tests and imaging where it's applicable is going to be important when we're drawing that whole picture of what's going on with the patient. But we have to remind ourselves that we don't always want to solely rely on the biomedical evidence that's available, because then, again, we're not painting the full picture of the biopsychosocial factors that might be affecting our patients' pain levels. Number 3 is to be mindful of comorbidities. Chronic pain often occurs with other health conditions, and we need to consider how these might complicate the claimant's overall health and recovery. So most of my patients with chronic pain aren't just another low back patient or a rotator cuff patient. Oftentimes they present themselves with predisposing factors or other comorbidities, and this can include diabetes, cardiac conditions, depression, anxiety, and all of those different types of comorbidities can also contribute towards the healing process of the patient as well. Last tip for tip number 3 is to document everything. Obviously, we want to keep meticulous records of all of our communication and assessments and decision-making processes that we have with multiple healthcare providers. And because when we are aligning all of those things in the different scopes of practice, we can help to fully support the claims handling process and potential appeals. And when you have all the information in front of you, it is easier to really grasp everything that's going on and that might be contributing to the delayed recovery of the injured worker.
Thank you, Dr. Allmond. Anything else?
Nope.
Thank you. That was really helpful information. I just would like to add, I think that it's important. So in addition to our own documentation, it's really important to ask and make sure that all of your provider partners are also documenting, because as Dr. Allmond said, it's a really important piece to be able to see the whole picture. All right, I believe this one is you, Dr. Pimentel.
Oh, muted. Okay, sorry about that. So like Dr. Allmond already hinted, there's so many different factors that go into or that impact chronic pain. So it is very important that you consider psychological or psychosocial factors. Chronic pain often coexists with psychological issues like anxiety or depression, which will be discussed later when we discuss chronic pain syndrome and psychological evaluations. But recognizing this can help you better understand the injured worker's experience and potential treatment needs. When it comes to chronic pain, we know that about 56% of adults will also experience depression and anxiety. So it'll be important for you to assess the injured worker's support system, understand the role of the family. Oh, can we go back?
Oh, sorry.
Friends and community support, and the injured worker scoping strategies and recovery process. And now we can move forward. Another thing that is very important is to understand the connection between, or the biochemical connection between depression and chronic pain. So there is serotonin, which is a neurotransmitter that is linked to both chronic pain and depression through the shared neurologic pathway between the two conditions. Serotonin affects or is involved in the processing pain signals in the central nervous system. It is a key neurotransmitter in the pathophysiology of depression and other emotions. Patients with chronic pain may have an imbalance which can lead to depression. And therefore, antidepressants can help reduce both pain and depression. And it may seem a little weird, you know, when a patient is prescribed an antidepressant for pain, but this is a reason why some of these medications are very effective in dealing with chronic pain as well.
For example, Cymbalta, an SNRI that addresses both. So it wouldn't be prescribed for depression, but it would be prescribed for pain, and then it has a positive impact on any depressive symptoms that are also there.
Mm-hmm. Yes. And so when it comes to working with chronic pains for psychologists, we're going to use the cognitive behavioral model. This is the way that individuals perceive a situation is more closely connected to the reaction than the situation itself. These situations directly impact our thoughts, emotions, and behaviors. So the way that the model works is that, okay, you have a situation, you got injured, right? And so that injury is going to elicit some thoughts, right? I have pain, this pain is never going to go away. You know, my day is ruined, now I can't get out of bed. And so you're going to experience depression, you're going to experience anxiety, frustration, anger. And what are you going to do? Well, you're probably not going to get out of bed. You're probably not going to engage in the activities that used to cause pleasure. You may isolate from your family, from your friends. And so that is going to worsen your situation. It's going to create more thoughts or more negative thoughts. It's going to increase your emotions, and it's going to create also more dysfunctional behaviors. We can keep going. And so this is another example. So again, you may think I'll never get better. And this makes us feel anxious, sad, and hopeless. We might tense our muscles, and then we might lie in bed all day. This will increase our experience of pain. So again, okay.
Want to go back?
Yeah, I wanted to just go over this really fast. So pain, you know, pain is going to create tense muscles, which is going to create more pain. It's going to create more anger, more stress, depression, fatigue. And this is how the cycle of pain continues, and it maintains and it increases. Another thing that's very important when we're talking about psychological factors is pain catastrophizing. And so this is the tendency to magnify the threat value of pain stimulus and to feel helpless in the context of pain and by a relative inability to inhibit pain-related thoughts in anticipation of, during, or following a painful encounter. This is associated with several pain-related outcomes, including acute and chronic pain severity, altered central nervous system pain processing, exaggerated healthcare utilization, post-surgical pain outcomes and disability, pain-related activity interference, depression, and other emotional disturbances. Reductions in pain catastrophizing are linked to a decrease in pain intensity, pain-related activity, interference, and disability. And so this is one of the research areas that has been found to be directly affected. There's a lot of research, there's a lot of studies done with children and adults about how our thoughts impact pain. And usually there's a screener where you're going to screen, the pain catastrophizing thoughts that the patient is experiencing. There's 3 domains that fall into it, including magnification. So your thoughts may be exaggerating the pain or the situation that you're in. Rumination. I can't seem to get it out of my mind. It's just constantly thinking about pain. You're not able to ignore these thoughts or distract yourself from them. And then helplessness. This is very important because this assesses this self-efficacy of the patient when it comes to their ability to manage pain. So for example, this one right here, there's nothing I can do to reduce the intensity of the pain. That tells us how the patient feels impotent and powerless to manage their pain. They feel out of control. They feel there's nothing they can do to somehow manage their pain or decrease the level of pain that they're experiencing.
Thank you, Dr. Pimentel. So again, folks, like this is a really helpful slide to help us catch hearing some. I mean, we all can recognize catastrophizing not only in pain, but just in life, right? So these are good things to be on the lookout for as you're managing your claims, and just kind of be on the lookout for these kinds of thoughts or comments that you're hearing. It'll be really helpful. Thank you, Dr. Pimentel. So next is tip number 6 with Dr. Ali.
Yep, thanks, Dr. Pimentel. So kind of segueing in from that, and very similarly, we talk about with chronic pain, there's this theoretical construct called the fear avoidance model of pain. And what that describes is the process for a lot of people that experience acute pain as it transitions into chronic pain. And so really kind of the foundation for the model involves obviously our emotions, fear, cognitions, attentions, behaviors that all kind of solidify more of these averse or fear avoidant behaviors and beliefs. The key element here obviously is the emotion of fear, which is in direct response to those negative beliefs that we are highly averse to actual and very important perceived level of pain. And so the problem with this is that fear becomes really tied with pain itself, and it leads to this preoccupation and desire for avoidance of activities and movements that could potentially intensify pain symptoms. And just very briefly, coming from a PTSD background too, this goes not just with pain, but also with fear avoidance of issues that happen with triggers about a traumatic event, right? So the more we avoid dealing with this pain or something that's psychologically difficult, the more those symptoms will exacerbate. So something that's very important to think about when we're dealing with chronic pain and those beliefs around it is how our cognitions can impact our relationship to pain. And so really thinking how we think about it can then help us manage how we experience it. And so the first step is to change how we think about pain, identify those unhelpful thoughts that increase our experience of pain. You can see SpongeBob's quite scared there. And so we're gonna go to the next slide as well. And so there are some questions that I use with patients when considering challenging our beliefs and thoughts about pain. And here's some of the ones that I use pretty regularly with my chronic pain patients. What is the evidence to support those particular thoughts about pain? What is the evidence against those thoughts, which is a very important question. We don't typically think about that. How might someone else view the situation? So getting an outsider perspective kind of helps us see things a bit more neutrally. I love this question. If this were happening to a friend, what would I say to them? right? We oftentimes give good advice, but we don't use it for ourselves. And so it's good to be able to take that perspective. And then another question is, am I only thinking of the negative, right? That's typically what happens. We have a negative bias, especially regarding pain. So it's important to kind of put that in perspective. So some of the ways that I've used, and these are actually real unhelpful thoughts that I've used with patients in the past. Here are some ways that we typically think about pain, and then I'll have them cognitively or positively reframe their cognitions. And so we have a few examples. The first one, I'm powerless over my pain. And so through the work, some of the thoughts that we have them change are, I am learning new skills from pain management, and I'm learning to control my reaction to my pain. So it's giving them a sense of autonomy to move forward. Another one, kind of life is a struggle, due to the pain. And so another helpful thought here is that life is full of ups and downs, and I'm learning to accept both. So you're taking more of this neutral kind of objective stance of what's been going on. And the next one, Yvonne. So what happens here is my doctor gave me an appointment a month away because he thinks I'm too much. And so sometimes we want to reframe that to say, well, my doctor is very reasonable, and I'm sure he was considering my needs when he scheduled. And part of that time gap is also to help increase their autonomy, that they're using the skills in an appropriate and effective manner.
Thank you, Dr. Ali. That was excellent. And next we have tip number 7. This is Dr. Allmond.
Make sure okay. So tip number 7 is considering an advanced transdisciplinary approach when addressing chronic pain. We now know that chronic pain is defined as persistent pain beyond that 6-month marker. And at this time in our injured workers delayed recovery, we want to consider integrating vetted and trusted healthcare providers from multiple disciplines to create solutions and frameworks that aren't confined by any single discipline. This team might include pain management specialists, PTs, OTs, speech therapists, psychologists, nutritionists, so that we can all use our combined knowledge and expertise to drive that cohesive and integrated framework towards a common goal. And in this manner, we can provide a comprehensive view of the injured worker's condition and treatment options to help them recover. Next slide, please. So in these next few slides, we're going to review the main differences between the most prevalent healthcare model in America, the biomedical model, versus another evidence-based model, and actually the preferred model to treat patients with chronic pain, which is known as the biopsychosocial model. Next slide. So you're going to see some pictures on this slide that many of our injured workers might relate to, and as they go through the typical biomedical model. And let's just say we use John Smith as our injured worker example. John has injured his neck and shoulder due to cumulative trauma from his job, and he eventually goes to see a doctor due to his injury. And he may go through some diagnostic criteria, whether it's x-rays or MRIs, and then he gets labeled by his injured body part. John Smith is now my left shoulder patient or my cervical patient. He may go through a series of interventions that may include, pain medication, doled out some physical therapy, maybe injections, or maybe even surgery. And then after all of these interventions, if he is still not better, usually we start putting on some, he might be given some work restrictions that are meant to protect the patient. No lifting over 10 pounds, no repetitive overhead activities, no bending, lifting, twisting. And although these measures are put in place to protect John from further injury, it's also sending him a message that movement could possibly be dangerous and further damage the injured body parts. And so John is going to continue to protect and restrict movement to these areas due to fear of pain or increased injury. So the focus in this model is just to treat the physical aspects of his injury. And so medicine and healthcare has traditionally been delivered through the biomedical framework, and it focuses on the anatomy, the biology, the pathology, and disease processes. And it assumes that any disease can be explained by a change in a person's biology or structure. Next slide, please. Now, I'm not here to say the biomedical model is a bad model by any means. Like mentioned above, we said that this model is actually effective for 80 to 90% of patients who sustain acute injuries, but that still leaves that large percentage of people, 10 to 20%, that enter into that level of chronicity in their pain, that their needs are not being effectively met. And so, and since that's the patient population we're discussing here today, we'd like to take into consideration what other healthcare models are out there that can better serve John's needs. So as you can see, there's even two types of approaches within the biomedical model. Unimodal means that he's being seen by a single discipline, maybe just by a psychologist, or maybe just by a PT. And then multimodal is when he is being seen by both the PT and the psychologist, but there's no coordination of care, let's say, between myself and Dr. Pimentel when we are treating John. And then the biopsychosocial model actually leads to this, these multidisciplinary approaches. So that means that now we have different disciplines that are treating, that are helping to treat John and meet some goals and outcomes. However, in the multidisciplinary model, we are treating independently from each other, and we don't necessarily share the same goals and outcomes. Whereas in the interdisciplinary model, now we're starting to integrate the multiple disciplines together and coordinating the treatment outcomes. So there's a little bit more overlap now. And then in the transdisciplinary model, now is that there's that full integration of multiple disciplines. Dr. Pimentel, myself, Dr. Ali, Dr. Che, we're all working together with, and we still have our different interventions that we're providing for this patient, but then we're sharing the same treatment goal, which might be eventually to return John back to work, full duty without restrictions.
I have to say, Dr. Allmond, I love how you presented this slide. That was a really great way to walk through it. Thank you.
Thanks, Yvonne. And so I'm gonna go into another phenomenon known as the biopsychosocial vortex. And this is when our injured workers or our patients get stuck in response to injury and illness. And so I'm gonna go back to John Smith because John is no longer just my left shoulder patient anymore, because now his injury has caused a huge shift in his overall identity. He's not able to perform his normal household chores. He's no longer gainfully employed. He's gained weight since he's not able to move and enjoy his normal hobbies like hiking or surfing. And this has affected his relationship with his family. It's caused him increased stress and anxiety. So John has now entered what we call the biopsychosocial vortex. And that's when the biological, psychological, and social factors are all interacting with each other in this complex and cyclical manner, and it's continuing to intensify and perpetuate his chronic pain. And in this vortex, these three dimensions don't just contribute individually to his pain, but they in fact amplify one another. And they're creating this negative feedback loop that makes the problems more persistent and more challenging to address.
Okay, so I love talking about this, and I want to give the first warning. We have 20 minutes left, so we're going to have to advance our pace a little bit, but love this information. Thank you, Dr. Allmond.
Thanks. And so the biopsychosocial model, I'm not going to go too much into this slide because I feel like we've hit a lot of this stuff already. But, basically it's those three overlapping domains of biology, psychology, and society. And when they all occur, and these things all occur within an individual and their environment. And so all three determine together the patient's overall health and well-being versus just the disease and illness. Dr. George Engel actually was the first person that proposed this framework back in 1960, and it was founded because he noticed a common mindset of his patients that were not necessarily cured by the biomedical framework. And he stated that patients, regardless of their level of education, preferred to blame their illness on something that happened to them. And because there's no single cause for the problem of chronic pain, the biomedical treatments, the token strategies don't necessarily resolve it. Next slide, please.
Oh, 1 second. There we go.
So in review, here's some key differences between the biomedical and biopsychosocial model. In that biomedical model, we're focused on that single anatomical disease. John is my left shoulder patient. Whereas in the biopsychosocial model, the focus is on John's overall mental, physical, emotional health and well-being. Treatment within the biomedical model is generally passive, medications, surgery, injections. It's usually given by another healthcare professional. Whereas treatment in the biopsychosocial model, the onus is actually on the patient. It requires them to be active participants in getting better. And then also there's that transdisciplinary approach where multiple overlapping professionals are aligned towards the treatment outcomes and goals. And then lastly, in the biomedical model, physical activities can sometimes be perceived as dangerous and avoided. These are our work restrictions: no overhead lifting, no lifting over 10 pounds. Whereas in the biopsychosocial model, we actually perceive physical activity as safe, healthy, and essential. When we look back towards the evolution of humans, we're not necessarily treated through passive means. And in the past, chronic pain was actually uncommon, and that's because humans were forced to move to keep moving in order to survive.
Thank you, Dr. Allmond. So our next tip is to create an individualized plan of care, and this is also you, Dr. Allmond, right?
Yeah, it's going to be all three of us. And I'm going to go through these next few slides pretty quickly because this is just giving us a sample. I just want to show you guys what's a sample of a transdisciplinary approach plan of care. And most importantly, at the very end, we just want to make sure that we are giving our patients long-term objectives and lifestyle modifications in order to reduce and manage their chronic pain and make it something that is sustainable outside of a program. Next slide, please. So here is a sample plan of care. We're going to use John Smith again, and actually this is a real life patient, pseudonym, but this is John Smith. He's a 52-year-old male, and he was diagnosed with chronic neck and shoulder pain secondary to cervical spondylosis. And he's been having pain for 3 years, and it's been exacerbated by multiple things such as stress, limited mobility, and resulting in depression. And so our goals, our treatment goals, are going to be to decrease pain intensity, improve function, and enhance emotional well-being, and eventually get John to go back to work. Next slide. And so here are some from the biopsychosocial side, the bio side of the interventions. And as you'll see here, you'll see 3 different disciplines working to treat his biological and medical interventions. We have a pain management team, we have a physical therapist, and we might have some nutritionists or lifestyle and wellness coaches. And they each have different objectives that are going to that they're going to work towards in order to meet John's overall goal and outcome to be able to experience a higher quality of life and to return back to work. Next slide.
Thank you. And so I think this one is you, Dr. Pimentel.
Yes. And so these are some examples of what the psychological interventions would look like. So in terms of cognitive behavioral therapy, the objective would be to reframe negative thoughts related to pain, improve coping strategies, and reduce pain catastrophizing. It would be 6 weeks with a licensed therapist. We would introduce a pain coping skills, including positive self-talk, relaxation techniques, and activity pacing. We would have them use a pain diary to track thoughts, feelings, and pain patterns, helping to identify triggers and reframe responses. And then we would also include a plan for mindfulness and stress reduction. This would decrease stress and improve emotional resilience to manage pain. This would maybe include an 8-week mindfulness-based stress reduction program, which would include practicing 10 to 15 minutes of guided meditation daily with a focus on breath awareness and body scanning. And then we would be assessing their symptoms and how they are progressing using certain questionnaires like the PHQ-9 and the GAF before and after the program. So we are, evaluating and assessing for improvements and where we want to intervene maybe a little more intense.
Thank you, Dr. Pimentel. And this one's going to be Dr. Ali.
Yep. And to kind of round that out, we also want to look at the social, environmental, and really cultural factors, and also can be very influential in the patient's recovery journey. And so one, looking at family and social support, it's really the objective of that is to improve that family social support and really help them understand the patient's pain management process. And so some interventions that can be used are scheduling a family counseling session to help really psychoeducate the family about chronic pain and what are some supportive behaviors to help them continue to improve. And so some of that can even include encouraging family involvement in non-strenuous physical activities with the patient, right? So we're trying to promote that mobility to help them improve. Also, workplace and occupational adjustments. So the objective with this factor is promoting a supportive work environment and reduce occupational strain on the affected areas. And so some of these interventions include collaborating with the patient's employer to implement ergonomic adjustments, so chair adjustments, standing desks, for example, and really helping to develop a modified work schedule to allow for breaks for stretching and posture relief if feasible. And so that we really work, IOH in particular, work closely with helping give those patients the appropriate adjustments back for a successful return to work. And then the last one we have is community engagement and social support. And so really the objective there is just to build a strong social support and reduce isolation while in treatment, but also post-treatment. And so some of those interventions include, referring folks to a local chronic pain support group to help normalize that they're not alone, even when they leave IOH. Helping them connect with others who are experiencing those similar struggles. And then again, providing information on community-based, low-impact exercise options like aquatherapy or gentle yoga, which we also provide at IOH for our patients.
Thank you, Dr. Ali. So this next slide, next tip number 9, I think is also you, Dr. Ali, but I think we can all agree that this is a really critical factor.
Absolutely. And so this one is important to really just educating our providers as our stakeholders, as the title suggests. So by being able to understand different pain management strategies within kind of the biopsychosocial atmosphere, it really helps us treat efficaciously in determining what's reasonable for what the injured worker needs to pursue. And so being able to familiarize yourself with different pain management techniques and their effectiveness through evidence-based practices will help evaluate treatment claims accurately. And so in my line of work as a psychologist, having a cognitive behavioral therapy kind of approach right off the bat is going to be super important for me because we know that CBT is kind of the gold standard when it comes to psychological intervention for chronic pain. And then, of course, is we want to educate stakeholder partners. And so making it a priority to share information about chronic pain with your colleagues and the stakeholder partners really helps foster greater understanding, awareness, which helps then build more compassion and really helps improve the claims process when managing those claims involving chronic pain.
Thank you, Dr. Ali. And tip number 10 is going to be Dr. Pimentel, but I wanted to say, I'm sure that you all see this in every presentation that is given in the workers' compensation system, but we cannot emphasize it enough, and it's so critical with these chronic pain claims. Right, Dr. Pimentel? Oh, you're muted.
Something that I want to emphasize here is the importance of the employer communication, because that really impacts how the patient is perceived that they're treated at work, really impacts how they feel and when they come to us. They may be very distrustful after experiencing certain interactions with the employers or the even other when they're provided other treatment. So when they come to us, they may be distrustful. And so this is important because when you maintain clear and supportive communication from the employers, you prevent escalation, right? And so a lot of the times patients, because they don't feel heard, they may, seek for an attorney or They may just feel that they've been betrayed and they don't know about their rights. So they seek more information, and their relationship with the employer may be deteriorated. So compassionate communication is going to be very important for the treatment of the patient, and to continue to trust their doctors and the treatment that they're given.
And also too, just a note on that is that because sometimes, particularly with these chronic pain claims, it's very difficult for them to manage what they're experiencing, right? So this is where we really need to exercise compassion and empathy for what they're going through. Thank you, Dr. Pimentel. And we have a bonus tip. And so Dr. Tilley, you've been awfully quiet. You're muted.
I did the same thing that I was telling Dr. Pimentel about. All right, and so one of the things that we see that is helpful, and then we see the opposite, which is unhelpful. And so working with a trusted partner, whether it's an Allmond clinic or their pain management or direct from the adjusters, is the ability to understand what a psychological evaluation for chronic pain means versus just a psychological evaluation in general. At IOH, what we have differentiated, we have called it a CBT eval for chronic pain instead of a psych eval for chronic pain. Nevertheless, it is a similar intervention, but the focus is on the chronic pain and the biopsychosocial aspects that are driving the continued delayed recovery. And so this is evidence-based. The M2S guidelines indicate that this is very important to provide to people with chronic pain. However, what we see is we'll get a response back that says psych is not an approved body part. And we absolutely know that psych is not an approved body part, and we are actually attempting to avoid psych being claimed as an approved body part. And so when you address through CBT the chronic pain syndrome that develops because of an injury with certain individuals, then you are able to avoid opening a psych claim. You are also able to help them recover because you are addressing the areas that need to be addressed. When you do not allow for a behavioral medicine specialist focusing on CBT for chronic pain, then you have a deficit in the full treatment that they need in order to understand what's going on, take a look at their thoughts, and progress. And so it's a strong encouragement to follow the M2S guidelines, to allow authorization and refer to trusted vetted partners that know the difference between a psych eval for chronic pain and a regular psych eval.
Thank you, Dr. Tilley. And when you download the handouts, there is a link to the M2S guidelines. And we have the ICD-10 code that we often use. So I know that we could do an entire presentation just on this, and I think maybe we should, because I think this is a really important element that the workers' comp professionals need to understand better in our industry. Anything else before we pass on?
Yeah, I would say that chronic pain syndrome is not a psych diagnosis. And so that is the diagnosis that is given for a psychological evaluation, for the chronic persistent pain patients, or a CBT eval, if there is nothing over and above. So, if there is over and above psychological factors that fall outside of the chronic pain syndrome, then that would be identified, and it's important to do so. But the vast majority get diagnosed with that chronic pain syndrome, and therefore a psychological body part is not being claimed.
Thank you. Again, I think all of the information that we shared today is super important, but this, Dr. Tilley, thank you so much for bringing this to our attention and sharing with our audience. So on this next slide, not going to read this slide. This is just, this is part of the M2S guidelines. And I wanted to also clarify in our original objectives that we sent out when we promoted this event, this webinar, we called one of the objectives red flags, and we decided to change it to indicators because red flags can mean different things to different people when we're talking about things in the workers' comp system. So these are right from the MTUS guidelines, and they are identified as indicators to help you understand when it's time to refer an injured worker to a more advanced model of treatment. So not going to read this, but this is a really helpful slide. You know, I would say keep this and refer to it often. And when you start to see claims that are going past that point of 3 months or even 6 months, it's really time to start looking at bringing in a more advanced model of care to help these folks recover, get back to work, and also help you to save costs. So we're getting up on close to our time here, but I wanted to take a quick second. We're not going to be able to have the discussion I was hoping to have, but to wrap things up, I would love for each of you to kind of share in your own words. So folks, we all work at Institutes of Health, which is the advanced biopsychosocial model of care that Dr. Allmond was describing before. I want you to each say one thing that you feel represents why it works. So I'm going to start with you, Dr. Tilley.
If you do not address the underlying symptoms, the psychological and the sociological, and just their feelings of helplessness, and they don't have the knowledge to understand what's going on with them, then they are the 10 to 20% that cost the most money to the insurance providers. Even though they're a smaller sect of people who, like through the biomedical get better, these 10 to 20 result in the 80 to 90% of the money that you are spending. And so it is very much in everyone's interest, specifically the patient, to get back to work, that you address this from the most evidence-based way, which is addressing the whole person and working with vetted partners that understand how to treat chronic pain.
Thank you. Dr. Allmond?
Can you hear me? Okay. Yeah, I mean, I just think that, with that transdisciplinary approach, we're getting those overlapping 3 domains and working together. And, I just go back to that biopsychosocial vortex because so many of my patients come into our clinic within that vortex that, where those 3 dimensions are just continuing to amplify their pain levels. And so when you are considering, chronic pain, we can't just consider the biological factors in the physical injury because that pain can then trigger the psychological distress that Dr. Ali and Dr. Pimentel talked about. And then those psychological factors then can intensify the perception of pain. And then the social factors, most of our patients go into, social isolation, feeling a lack of support. And this may worsen the biological and psychological impacts on their pain levels. So it's creating that self-sustaining cycle. And, in order for us to break the cycle, all 3 disciplines have to work together. And, it's beautiful to see when it's actually in work because it brings about so much hope for our patients who have been lost in that vortex for so long. And they see that big picture and they see that road to recovery. So, I'm a huge believer in, evidence-based care and how the biopsychosocial model can really effectively help heal an injured worker with delayed recovery.
Thank you, Dr. Allmond. I know that you had a patient coming up soon, so we're going to try to wrap it up and leave a couple minutes for questions. There are some. Dr. Ali, what is your takeaway, and why do you feel the biopsychosocial approach works?
Yeah, and I'll make mine quick too, just to kind of piggyback off a little bit. From a clinical perspective, I've seen it firsthand how effective it can be for patients to receive that support in all these different domains. And so people with chronic pain oftentimes struggle with sleep, and so we've got that covered here. Struggle with nutrition, we got that covered here. Psychologically, physiologically, everybody working together. It's kind of an all-attack approach, and that really helps get patients needed in a one-stop shop for what they need and to get it most effective in a very timely manner. So I can speak from my own anecdotal experience, very, very effective. And then just from a financial perspective, I think it really helps save those healthcare costs. You are getting this treatment expedited in all different domains in order to help them get back to work most effectively. and help them improve their life, but also then gets them back to their own kind of quality of life with their families, gets them back to where they need to be for work, and it helps save the employer and healthcare costs in general, that things will come down. So I think clinically, financially, I've seen it be extremely effective, and I'm a huge believer in it. And yeah, this is the way to go.
Thank you, Dr. Ali. And Dr. Pimentel, your thoughts?
Yeah, so why it works, I believe it's the fact that we really emphasize self-efficacy, that you have some control over your pain. You can change your pain with your own behavior, right? It's like behavioral medicine, with your own thoughts. If we can change the way that you're thinking about your pain, the way you perceive your situation, the catastrophizing thoughts, we can really help in helping you make better choices so that you can improve your pain. And so this is you doing it. You don't have to wait for a doctor to tell you what to do. You don't have to wait, for medications to work and maybe give you side effects. This is you doing it. This is you choosing, okay, I can get up, I can question my thoughts and challenge the negative thoughts that I'm having, and get up and do something that's going to help me improve my day, improve my pain. And so that's what we're doing. We're giving the tools to these patients so that they can take them home, so that they're not, they don't have to see a doctor, forever. They can take these tools, they can implement them at home and improve their symptoms.
Thank you, Dr. Pimentel. So thank you, panel. You did an amazing job of getting through a lot of information. We're just a couple minutes over time now, so I'm going to start reading the questions. And thank you, audience, for those that are still on. So the first question that I have is, can the amygdala response be modified with psychotherapy? Who
I think
wants to
that's Dr. Ali, the amygdala, yes.
Yes, so we know that the amygdala, which is kind of that emotion center in the brain, when we work through our chronic pain symptoms psychologically, being able to kind of reduce that physiological and emotional arousal is very, very important with pain, because we have this heightened sense and alert to pain. And so some of the interventions that we work to reduce that amygdala response is through mindfulness, is through diaphragmatic breathing, even cognitive reframing. When you're allowed to see a different approach, a more positive reframe, a hopefulness usually arouses, and that also reduces that kind of reactive physiological response. And so absolutely through psychotherapy and interventions there, we know that that amygdala response can come and slow down.
And if I can add something, there's studies that report that sometimes patients can experience pain even before the stimuli has happened. So just from thinking about it, just from remembering maybe pain in the past that they've experienced. And so these are all linked to that emotional reaction of the amygdala as well, based on memories. And so being able to process all of these emotions and memories, painful memories, can really impact the way that you start to perceive pain and maybe not react to pain before the stimuli happens.
I'll just piggyback off one thing with that too, is that you're essentially creating new neural pathways in your brain to how you respond and relate to pain, which then starts to give you that healthier sense of what's the emotion needed to deal with this, specific issue.
Thank you. Okay, next question is, does serotonin decrease the production of cytokines? I don't know if I pronounced that well, right? From the glial cells.
I think that's going to be a Google answer. We are not at that in-depth of knowledge of biology.
Okay, maybe we should do
Well.
where we get into those deeper things. All right, so the next question is, do any of the claimants who continually allege ongoing symptoms and lack of ability to manage pain through the years of their claim ever actually seek further treatment with you once they receive their settlement check for resolving future medical care?
Absolutely. We have a significant amount of patients who come to us after they've been permanent stationary, they're treating on future medical, and they are still looking for relief. And a lot of our job at that point is education. Education, self-management, movement. all supported by, you know, the entire team. It does take a team approach oftentimes at that point, because everything else they've tried has not worked. And so we have had people who arrived to us on walkers, and that at their graduation, they, you know, advanced to a cane during the program, and then the cane is in the trash when they leave. That literally just happened, I think, a month ago. And so, yes, it is possible to recover no matter at what point you seek treatment. And the goal, as Dr. Allmond said, is increase function. And so it's coming from all the different angles to give them a better life and to be able to self-manage what is going on and not to feel so hopeless.
Okay, great. So this next question, I predicted this question might come up. So would a functional restoration program be more helpful to a patient within the first 24 months of chronic pain versus 5 to 6 years later? What are your thoughts on when an FRP should be asked for by the treating physician? Who would like to take that?
I can.
Yeah.
Yeah, and actually an FRP program, you know, when I go back and review those 4 essential pain facts, the longer a patient is in pain for, the harder it is for them to recover, because they are stuck in that biopsychosocial vortex longer. So the earlier we can get our patients in, the less sensitive their pain system hypersensitivity is. And it does not mean that we don't have patients that injured themselves 5 years ago, 10 years ago, still make significant gains within our program, but their bodies have learned a certain degree of pain as their baseline now for the past, you know, 5, 6, 10 years. So it does require a little bit more of a nuanced and complex plan of care, but yeah, you know, even at the 5 to 10 year marker, even though the recovery is going to look a little bit different than someone that we get at the 24-month marker, the biopsychosocial approach is actually, you know, probably their best hope into, you know, forming that new baseline.
And if you do want to avoid, the protracted 4 to 5 years, that you will deploy an early intervention based treatment program. And so addressing those symptoms as soon as you identify, which is, you know, 3 to 6 months. Mm-hmm. And unimodal, you know, they've exhausted conservative care. They've done CBT sessions with an effective treatment provider. If it remains delayed recovery, that is when you would want to explore other opportunities and seek out, you know, an evidence-based, effective, transdisciplinary therapeutic community functional restoration program that, you know, has the full bandwidth of providers treating. We're talking many domains here. It's not just, you know, one physical therapist, one psychologist working with the patient for an extended amount of hours. You want a whole transdisciplinary team identifying and rectifying what is going on.
Thank you, Dr. Tilley. And absolutely, the 24-month reference, the earlier, I mean, we've been talking a lot internally about it's really that year to 24 months that's really critical. When you get to the 2-year marker, that's when you really start to see the costs escalate. So it's really important to identify these claims and get them some advanced assistance to help them recover and get well. All right. I think I saw one last question. What if the patient does not want to take this approach? I feel there are a lot of people that do not want to have to do the work to make their problems better. Do you continue to treat them?
So for individuals like that, which again, we see quite often, because that's where a lot of them start, it is important to try. And if we are not able to overcome the biopsychosocial vortex factors and all that they've got going on against them, then at a certain point, you're understanding that, you know, now is just not the right time for them. Perhaps in the future, but now is not the right time. It takes a lot of motivation and hard work on the patient's behalf. And if you know, after all the interventions are tried, etc., you would not want to continue having them be at this level of care if there's not objective functional improvements. So you want to make sure that you're testing that all along the way at the milestones, and then developing a different treatment plan if it's not moving as would be expected.
And I want to add that we do get a lot of patients that are resistant, and that we are able to change their mind once, you know, they get the right information, because a lot of the times these patients, they're so unmotivated because they've never been informed about their pain and what their pain is and how they can improve it. And so once they hear some of this, and we talked about how depression and anxiety affects them, you know, they may never have been heard about their depression or anxiety. They probably don't even understand that there's a link between their depression and their pain. So when we explain that to them, a lot of the times we're able to change their minds about the treatment, and they're able to buy into it. So giving them that opportunity to try that. And then again, like Dr. Tilley mentioned, you know, if there's no improvement, then there's no need to request more hours for them. So we do.
And I would say that within the therapeutic community, it's a milieu, and as much as we explain, which is very important that we explain and provide knowledge, they see it because they see other patients, and the other patients tell their story. So it's the experience of the collective that, you know, is hugely important on increasing their hope and their thought that I could actually do this. And so that is one of the hugest factors of overcoming the resistance.
Mm-hmm.
I think we got all the questions, Diane.
I think you got every single one of them. Thank you so much. I want to say that what a great program this was today. I know that our audience had to have enjoyed it very much. The fact that we have 4 doctors on at one time is really a treat for us. Yvonne, you did a fantastic job. We want to thank the Institute for partnering with us today. And doctors, thank you all for sharing your knowledge. Until next time, we will see you at the next Macro Pro Conference. And I do want to remind everybody that December's coming up, and we will be doing the 12 CEUs of Christmas. So look for those flyers and information on how to sign up for those. All right, everybody, have a great day and happy Thanksgiving.
Thank you,
Bye-bye
everybody.
now.
Happy Thanksgiving.
Happy Thanksgiving.